were disabled who had suffered some kind of mental damage. By 1941, the exclusion criterion of war service was eliminated. And in the unfortunately somewhat brief and cursory study that I made of this, there was always a great deal of caution and an attempt to exclude elderly persons, that is, people who were suffering from senile dementia as a result of the onset of older age. Those people were, there was a very cautious approach to the elderly, and it was not, as sometimes stated, at least from my reading, that the elderly were encompassed with all the others. It was primarily those who were unfit for work at a time in life when one would expect them to be more socially and economically productive. A different approach to slippery slope arguments contends that even avowed opponents of that form of argument may have unwittingly begun the slide themselves. Thus, Richard John Neuhaus, citing Daniel Callahan's rejection of the Nazi analogy in his, Callahan's, discussion of quality of life, Neuhaus observes that Callahan himself has already slid. Quote, Daniel Callahan is a spirited opponent of the slippery slope metaphor, but his own emotional preparedness with respect to the treatment of the dependent and incapable has undergone a remarkable development. Still quoting, in 1983, he, Callahan, wrote forcefully against withdrawing food and water. 4 years later, Callahan invites us to discard that moral emotion, end of quote. According to Neuhaus, Callahan has slid because to hold that nutrition and hydration food and fluids, may ethically be withheld, requires the erasure of two distinctions of long standing in medical ethics and practice. The first distinction, Neuhaus says, is that between ordinary and extraordinary means. And the second distinction is between medical treatment and providing food and water. A vast literature on the vagueness and ambiguity of the ordinary-extraordinary distinction and recent work by the President's Commission seem finally to have laid to rest its utility for the purpose of making ethical judgments. Moreover, one feature of the oft-quoted statement of Pope Pius XII has the potential for being morally pernicious. The 1957 statement, oft-quoted by Pope Pius XII, that statement holds that, quote, normally one is held to use only ordinary means that do not involve any grave burden for oneself or another. Now, what might constitute a grave burden for another? A great expenditure of money required to sustain hospitalization and life supports? The agony of a family watching a loved relative linger on for months in an intensive care unit? The provision of frequent and unpleasant nursing chores to an incontinent, bedridden, elderly patient with Alzheimer's disease. This feature of the ordinary-extraordinary distinction makes it a criterion for foregoing treatment that is not exclusively patient-centered. This, I would argue, opens the door to far wider abuses than abandonment of a distinction found to be unhelpful in medical practice today. To erase that distinction between ordinary and extraordinary means seems to have been a moral gain rather than a slide down the slope. Still, it is easy to see how withholding food and water can be assimilated to Nazi practices. The Nazi doctor Hermann von Muller was credited with the policy of starving to death those selected for the children's euthanasia program rather than wasting medication on them. According to the account of one visitor to the institution von Muller directed, von Muller is said to have said, quote, "We do not kill with poison, injections, etc. No, our method is simpler and more natural, as you see." Again, this is in the words of a woman who had been visiting. The murderer, meaning von Muller, explained further then that sudden withdrawal of food was not employed, rather gradual decrease of the rations. A lady who was also part of the tour asked, her outrage suppressed with difficulty, whether a quicker death with injections, etc., would not be at least more merciful. The irony of the visitor's question is a reminder of a core ingredient in the meaning of euthanasia. A lethal injection might very well bring about a more merciful death than starvation for these children. But unlike patients in the last throes of terminal illness, the children in the Nazi euthanasia program were deliberately selected to die. It is a cruel irony to voice an ethical indictment of the mode of death when it is the very fact of death that constitutes the moral outrage. The same moral judgment, I maintain, obtains in the cases of Baby Doe, cited earlier in Bloomington, Indiana, and an earlier case at Johns Hopkins University Hospital more than 15 years ago. The fact that these infants were not fed and hence starved to death addresses the lesser of the moral evils. Both infants could have lived if their parents had not refused to consent to surgery to correct their intestinal malformation. And both would have lived had a court order been granted to override parental refusal. There's every reason to believe that these infants suffered. But there's no reason to believe that irreversibly comatose patients, or those in a persistent vegetative state, suffer when artificial nutrition and hydration are withheld. These patients have no awareness of their surroundings, nor do they experience sensations. They do not respond to any stimuli, most not even to deep pain. The part of their brain that enables them to have experiences has ceased to function. Therefore, they cannot suffer, either from starvation, dehydration, or continued medical treatment. Whether withdrawal of life supports from such patients should be termed euthanasia is a conceptual question. Whether withdrawal of medical treatment, including artificially administered nutrition and hydration, is ethically acceptable is a separate and distinct question. Now, there's a third group that remains camped at the base of the slippery slope, watching and waiting. Gregory Pence, one writer, is prepared to wait and see whether what is for many people the most worrisome practice, that is active euthanasia as currently practiced by a few Dutch physicians, whether that will precipitate the slide. Pence writes, "What will happen in the future is difficult to predict. A statute won't solve all problems because it cannot be drafted broadly enough to cover all patients and precisely enough to close all loopholes. In any case, the Dutch experience may show whether mercy killing leads to Auschwitz, civilized death, or somewhere in between." Another writer in this camp observes that there's more than one slope to slide down. Lawrence McCullough argues that the accuracy of the comparison between the Nazi euthanasia program and our own biomedical practices depends on which features are taken to be relevantly similar or different. He writes, "We see that what got German society on the slippery slope, indeed what characterized the slope, was the racist attitudes already in place. It is a reasonable defense and distinguishes our case from theirs for us to say that we don't have those attitudes. Our slippery slope may yet be analogous to Germany's in a more abstract way. If we consider the rationale which gives social utility or economic returns precedence over individual freedom, then we might see how our society could approach the kind of thinking that underlay the Nazi experience. There, racism overrode personal autonomy. Here, McCullough writes, it might be an economic rationale, the attitude that we won't spend so much per year to keep somebody alive on the slim chance of recovery." This view is echoed and reinforced by Alan Weisbart and Mark Siegler, Alan's also here today, who observe that one slide has already begun and now is the time to be vigilant. Their concern is the acceptance of withholding of food and fluids from dying patients, conjoined with recent furious efforts to control the costs of medical care. Weisbart and Siegler write, "We have witnessed too much history to disregard how easily society disvalues the lives of the unproductive, the retarded, the disabled, the senile, the institutionalized, the elderly, of those who in another time and place were referred to as useless eaters. The confluence of the emerging stream of medical and ethical opinion favoring legitimation of withholding fluids and nutrition with the torrent of public and governmental concern over the costs of medical care powerfully reinforces our discomfort. These different worries about the prospect of sliding down a slippery slope are instructive. Each reveals a somewhat different value bias about euthanasia, what practices are unacceptable and what we have most to fear, or which of several slopes are most dangerous. For Newhouse, it matters not whether euthanasia is passive or active, voluntary or involuntary. All are morally wrong. Using the technique known as persuasive definition, Newhouse subsumes all forms of euthanasia under his broader heading, the eugenics project. For Gregory Pence, it appears to be both the continued voluntariness of the Dutch practice of euthanasia and its success in maintaining the limited conditions under which active voluntary euthanasia may be performed that would permit the practice to be ethically acceptable. For McCullough, the slide down the slope can be halted so long as personal autonomy remains paramount and is not overridden by economic considerations. For Callahan, the key lies in paying strict adherence to an acceptable standard for assessing quality of life. So long as borderline cases are not excluded from the human community and denied life-preserving therapies on the grounds that they are lives not worth living, according to some comparative social standard, we can avoid the murderous tendencies of the Nazi regime. My concluding section is entitled "The Most Dangerous Slope." Critics of today's practices contend that what is afoot is at least the inception of a programmatic effort to terminate the lives of some patients. Kronberg, the earliest author I referred to, who wrote that inflammatory piece, refers to the modern euthanasia movement, claiming that it is scarcely different from its Nazi predecessor. Newhouse refers to the eugenics project, which he takes to include cessation of life-sustaining treatment. More circumspect and less polemical critics, such as Weisbart and Siegler, assert that the death with dignity movement has now advanced to a new frontier, the termination or withdrawal of fluids and nutritional support. Whether today's medical practices regarding termination of treatment are referred to as a project or movement, or described in morally neutral terms, numerous writers remind us that the Holocaust did not begin with a euthanasia program. Not only did it start from small beginnings, it was preceded by a period in which resources were scarce, when it was a temptation to adopt, as one writer put it, a narrowly materialistic perspective for the establishment of priorities, and to seek savings through shortcuts at the expense of those who were weak and less able to defend themselves. It is just such considerations that lead to worries about where we are headed today. Leslie Stephen Rothenberg, one of the contributors to the Hastings Center's project on termination of treatment guidelines, has dissented from several sections of these guidelines. He expresses the fear that the guidelines, quote, may be used to give a moral imprimatur to undertreating or failing to treat persons with disabilities, unconscious persons for whom accurate prognoses are not yet obtainable, elderly patients with severe dementia, and others whose treatment is not believed cost-worthy. Withholding or withdrawing life-sustaining therapy from patients whose continued treatment is not cost-worthy bears a much greater similarity to the Nazi euthanasia program than does the current practice of active euthanasia in the Netherlands. The cost-worthy rationale also bears a greater similarity to the Nazis' purpose than does the current practice of complying with patients' requests to forego life supports or following their advanced directives regarding medical treatment once they have lost decisional capacity. A careful reading of the Hastings Center's guidelines on the termination of life-sustaining treatment reveals a good deal of caution. There is an admonition, quote, to avoid discrimination against the critically ill and dying, to shun invidious comparisons of the economic value of various individuals to society, and to refuse to abandon patients and hasten death to save money. There is a concerted effort in the section entitled "The Use of Economic Considerations" in discussing concerning life-sustaining treatment to retain a patient-centered ethic in medicine. Yet, despite these cautions and concerns, the guidelines acknowledge the relevance and importance of considerations of costworthiness. One statement begins with the prohibition, quote, "The healthcare professional caring for an individual patient should not be involved in cutting costs or rationing scarce resources at the bedside for the benefit of society." Yet the sentence ends with the proviso, "unless it is in accordance with institutional or governmental policy." This now brings us back to the case with which I began, the family of Holocaust survivors who were unwilling to reduce the level of care being provided. The patient's physician did not want to be the one to ration resources at the bedside. There was no institutional policy in place. One ethics committee member questioned whether the hospital ought to have such a policy, making it easier for physicians to tell patients or families that an official policy required care to be withdrawn. The Hastings Center's guidelines state that, quote, "When such policies have been developed according to procedures and standards that are reasonable and just by governments or by institutions, it is ethically justifiable for healthcare professionals to follow such policies and to refuse to provide this treatment." Well, in conclusion, whether it is accurate to call reducing the level of care for this patient euthanasia is not the moral issue. Terminating treatment would not count as euthanasia according to several of the definitions discussed earlier, but might fit other definitions. I find it ironic to note that, on one account, it would not count as euthanasia, but would fit the description of the Nazi program. This account reads, and I've quoted it before, "The decision to terminate the life of a patient under the Nazi program was taken not by the individual concerned or by his or her relatives, but by an official body. The criterion was not the welfare of the individual patient, but whether or not the patient's life was judged to be of value or worth to the community." Some find the possibility of allowing active euthanasia, even the voluntary kind, to be the most worrisome prospect. Others fear that from an ethical standpoint, the most dangerous practice is withdrawing or withholding treatment involuntarily, that is, from patients who lack decisional capacity. I maintain that a far greater danger lies in use of an economic rationale. When the justification offered for terminating treatment is that it is not cost-worthy, or that it is consuming a disproportionate amount of society's or an institution's resources, the slide down one of the slopes to the Nazi program has already started. As Robert Proctor has observed, the argument for the destruction of life not worth living was at root an economic one. I do not suggest that efforts cannot be made to halt a slide that has begun. But when a society regularly and systematically confuses economics with ethics and uses cost-benefit analysis as its only tool in forging health policy, it will fail to recognize the most dangerous slope of all. Thank you.
That he cut it down, I think, remarkable. Let me move on to the panel and apologize at the outset for the brevity of the introductions, but the point is to hear what people have to say. The first speaker will be Dr. Robert Berger, Associate Professor of Surgery at Harvard University Medical School, who's also affiliated with New England's Deaconess Hospital.
I guess I'm supposed to speak, but after this talk, I'm almost speechless. Let me tell you where I'm coming from. I'm a Holocaust survivor, but that's irrelevant. I've been doing academic cardiac surgery for the last 25 years, have been engaged deeply in research, human research, and have done a great deal of work in hypothermia. I don't know if you know that any time you do an open heart operations, you put a patient into hypothermia. There are approximately 300,000 open heart operations done in this country annually under hypothermia. So there's a great deal of information available in this country from hypothermia. I got involved with this whole Dachau business about a year ago when I was watching a McNeil-Lehrer report. And Drs. Kaplan and Pozos were there. And basically they claimed, or at least Dr. Pozos claimed, that you can save human lives if he used the results from the Dachau hypothermia experiment. Now, I didn't know anything about, I knew that people were cooled in Dachau, but I didn't know anything about the results. Well, I said to myself that how is it possible that, let's assume the experiment was designed scientifically, was carried out accurately, how is it possible that the technology, which was primitive in the 1940s, would have any application to what we're doing in the 1980s? So I began to have questions. And went ahead, and for the last 2 months, I done a great deal of research on hypothermia. Dr. Pozos and I may not have read the same material, but I suspect that is not the case. Now, I have 5 minutes to answer what Dr. Pozos had to say. And it's difficult. I don't think ever in my life I've been in this difficult situation. Dr. Pozos is a highly respected physiologist in hypothermia. He has written extensively, at least about laboratory hypothermia, and participated in some clinical reports on recovery of people from immersion hypothermia. But I just don't know. I don't know where his information is coming from. I think it's distorted. I think it's unilateral. I don't think it had any careful scientific evaluation of his presentation. For example, the description of Dr. Rasher is totally incredible. This man was a fraud. Some of his other work was totally incredible. Let me tell you, for example, what one of his experiments was. He decided, he concocted some kind of a pill called polygol. And he felt that the use of polygol would reduce bleeding from surgical wounds or wounds sustained in combat. There was no scientific basis for this. As far as I can tell, there was no reported laboratory testing of this study. He took some prisoners, put them in a chair, put another chair behind the prisoner, stood up on the chair, took a weapon, put it on the shoulder of the man, and aimed it so that the bullet would traverse the chest and penetrate the upper abdomen. Then the fact that one of these subjects or victims survived for 20 minutes, and those 20 minutes were pure agony, he claimed that polygol is going to save humanity. And if it had the functions that he claimed it would be of major significance. It would be Nobel Prize type of a treatment. People who would be wounded would not bleed. People who would have surgery would not bleed. Penicillin doesn't come near it. And then 2 surgeons were willing to use this polygol before an operation, and Rasher got a report from these 2 surgeons that the polygol reduced surgical bleeding significantly. It's pure sheer nonsense. The man was a hoax. He was recognized as a hoax in his medical school days when he submitted a research project necessary for his graduation. For funding, it was found out that his project was a hoax. He could never, and subsequently he never received a university appointment in spite of the fact that a powerful man like Himmler was very strongly behind him. I did not see Dr. Pozos's presentation before. I just didn't expect this presentation, and I only have 5 minutes, and I'm a little bit disturbed and puzzled And I thought, I have a 20-minute session tomorrow morning, and I think I'm going to get organized some of the material that I have, and I would like to respond to Dr. Pozos tomorrow morning. Thank you.
Dr. Benjamin Friedman is Associate Professor at the Center for Medicine, Ethics, and Law at McGill University in Montreal. He's also the clinical ethicist at Jewish General Hospital of Montreal, and he's next on our roster.
Horace has written, "It is when I am struggling to be brief that I become unintelligible." To this I can only add, but not only then. I'm going to speak exclusively on the ethical question of the use of Nazi experimental results in what I thought before I got my new marching orders is a truly brief paper, perhaps the briefest paper that I've ever delivered, and I'm going to give that same paper now, but at a much more rapid speed. So please bear with me. Let me note at the outset of these remarks two difficulties in the concept of using experimental results. What is it that we mean when we speak about using experimental results? What is meant, first of all, by Nazi results? We think we know, and Dr. Pozos certainly was talking significantly of the fruits, the evil fruits of the Nazi enterprise. Dr. Seidelman, in a superb presentation earlier today, reminded us that there are many more results that are implicated within this that significantly predated and indeed contributed to the genesis of the Nazi enterprise. We would need, in thinking about Nazi results, to include these seeds as well as the fruits that Dr. Pozos referred to. The circle widens. We need to concern ourselves about a great many more experiments, a great many more scientific investigations than we had thought. What is meant, I think, more significantly, more interestingly, by the concept of using data. Data can be referred to by citation or otherwise, serving as a presumptive empirical substrate for a scientific argument. That's one use. Data can ground, secondly, a medical conclusion, which could then serve to establish, validate, or justify clinical practice. A third use. Data can serve to suggest further areas for inquiry. The term, the use of the data, equivocates between these three different meanings. Moreover, the three meanings fail in combination to exhaust the meanings attaching to the term. Without clarification of this question, it will clearly be hard to reach an ethical conclusion about the use of data. The first meaning might prohibit published and unpublished citation, and might prohibit the pursuit of protocols whose scientific grounding is crucially reliant upon these results. A prohibition with respect to the second meaning, and here is where the shoe pinches, the second meaning being use as grounding clinical practice, might require that use of a therapy proved superior by the data be avoided. In other words, that a known inferior technique be used upon patients. The third meaning, use as suggestive of lines of inquiry, may be both the most frequent and the most evanescent way of using data. The moral implications of prohibiting the use of the data in this sense are not easily drawn. Perhaps consciously induced amnesia, perhaps conscientiously induced amnesia. I'm going to concentrate my attention upon unpacking one specific argument against using data derived from the Nazi experiments, an argument that relies upon the symbolic significance of such use. I've reached in my own mind a conclusion about this argument. I think it wrong for reasons that I'll explain. But because this symbolic argument is ordinarily presented in conjunction with other arguments rather than as a distinct reason for driving to the conclusion of rejecting use of the data, I will briefly comment upon what appear to be more common arguments for the same conclusion. Probably the most frequent reason for rejecting use of the Nazi data, one that goes back to General Taylor's arguments before the Nuremberg Tribunal, is that the data represent bad science. We've heard about this kind of argument a moment ago. The claim is subject to various parsings. The claim might be, as Taylor had suggested at least one point, that the result in question could have been demonstrated by bench science without the use of human subjects, and so the experiments were unnecessary. The claim might be that the results cannot be trusted because the experimenters were untrustworthy, or that the results cannot be extrapolated to human beings not subjected to Nazi privations and deprivations. I won't comment about these arguments except to say that all of them are at bottom arguments against using poor data or against the inept use of good data rather than use of Nazi data or evil data. The argument would presumably hold as well against poor data collected in an ethically impeccable manner, and so it's not an argument specifically relevant to our problem. The second argument served to ground the decision of editors of medical journals to refuse publication of results achieved through unethical means. The concern here is to deter researchers who would otherwise have motivation to pursue unethical shortcuts in the interest of their careers. There are a number of things that I wanted to say about this. I will simply say that as a deterrence argument, don't publish, don't use this in order to deter people in the future. This seems to me wholly inapplicable to the question of the use of Nazi data. Evils of the Nazi era, including human experimentation, are many orders of magnitude beyond those that may be deterred by such actions as an eschewal or condemnation of data use. The arguments upon which I would like to focus are symbolic in nature. They state that science should stand aloof from data derived from such a source. Can I have some water, please? How are we to understand this argument? We are talking of the use of data, not participation in these heinous studies, not replication of atrocities. The wrongs perpetrated were monstrous. Those wrongs are over and done. How could the provenance of the data serve to prohibit their use? What ethical structure or theory could, within bounds imposed by logic and plausibility, ground a relationship between the provenance of the data then and its use now? I will canvass possibilities, but confess that I remain honestly puzzled by these questions nonetheless. It could be felt that by using the data now, the wrong of which they have grown is retroactively increased. By using Nazi data, we prolong the Nazi project and perpetuate that evil. We keep that project alive and add an increment, however small, to its evil. One response might be that the Holocaust must not be trivialized by use of this kind of an argument, given the disparity between the evil of that era and the small modern increment attaching by hypothesis to the use of the data. I respect those who object to this form of trivializing, who see the Shoah as sui generis and therefore prohibit comparisons, analogies, and in this case, extensions. I respect that, but I do not stand with them. The Shoah exhausts the ethical ability to imagine evil. But for one committed to ethics as analysis rather than imagination, this road cannot be taken. Evil in my own analytic understanding is inexhaustible. The most horrible crime we have experienced is made worse by adding to it a further wrong, however minor. My response would therefore come along different lines. First, the current scientific and medical use of these data is not an extension of the Nazi project. The use causally depends upon that project. The project has perished. The remaining detritus has been co-opted for quite a different purpose, one in fact antithetical to the intentions of Nazis. I would say something further. If contemporary actions could retroactively alter the ethical significance of actions, the alteration must in principle be capable of going in both directions. There are some who indeed say that the data must be used for such use has redemptive value. This is the view which, extended somewhat, underlies talk about salvaging some good from the ashes. I'm troubled by this view. Is the wrong diminished, diminishable in any way whatsoever because of good which is mined from it afterwards? Were the lives of those sacrificed, of these korbanot, in some need of redemption, so that their lives and deaths become infused with meaning because of what this has meant to others following them? I cannot accept the view that later actions causally dependent upon the results of the Shoah can retroactively alter the ethical significance of that event. At a deeper level, I am concerned here as elsewhere at a view of ethics as outside of the realm of causality, as a kind of miasma unbound by time that allows for the retroactive undoing of past wrongs by a later consent or withdrawal of data obtained deceptively. My colleagues in bioethics know what I'm speaking about. Another symbolic reason given why science must stand aloof and not use the Nazi data is the belief that the evil of that time somehow infuses, insufflates the data, and so we who use them are tainted, rendered unclean by this contact. One who uses the data in this view demonstrates thereby ethical, metaphysical obtuseness. I say these words, but I do not understand them. As a philosopher and an ethicist, I understand ethical evaluation as attaching to human actions, not to objects, nor to mathematical representations of objects. In spite of not understanding, though I have heard this argument, perhaps from within, I will respond. The specific manner in which evil, the Nazi taint, infuses the data will depend upon a specific understanding of wherein that taint consists. The project of understanding the Nazi horror is, in my own view, one incumbent upon each person, certainly upon each Jew, by reason of the commands upon each individual to remember Amalek and to write for themselves a scroll of the law. For my own part, as described elsewhere, I understand the essence of evil itself to be, in the words of Rabbi Adin Steinsaltz, the bursting of bounds, that which breaks out and goes beyond proper limits. Following Robert Proctor, my own individual understanding of the unique nature of the Nazi evil, has been put with spare understatement as, quote, Germany carried to an extreme policies that were present in milder forms in other countries. At any rate, however, I cannot see how one could feel so confident of having accomplished the task of capturing the essential Nazi evil as to derive normative implications from that project. There's a quick third symbolic argument. You make a statement, it is suggested, by refusing to touch this data. As an ethical argument, though, rather than an expression of repugnance, this presumes what needs to be proven, that the use of the data is morally wrong. You can only make an ethical statement if, by doing so, you are doing the ethically right thing. Moreover, to make a statement, in my understanding, you're best off by making that statement. You don't make a statement by ambiguous silence, which in my own experience may be consciously or unconsciously more of the uncomfortably averted gaze than of the steadfast, conscientious objector. This brings me to a fourth and quick final parsing of the notion that science must stand aloof from the Nazi era by not using the Nazi data. It is this. By using the data, one would necessarily be saying something about the event, by way of excuse, mitigation, or simply by admitting the events of that era within human history and the scope of potential behavior. This argument is similar to the first, but importantly different. In the view I am now examining, by using the data, one does not join oneself to the Nazi project, but necessarily is seen by others, even if you like, misconstrued by others, as saying that the events of that time are not so hideous that they must be bracketed off from all future human experience. Yet could it be that one is necessarily saying one thing about the Shoah and using the data, contrary to one's own intention and motivation? A moral universe such as our own depends primarily upon the actors to attach symbolic significance to their own actions. In this case, in particular, such an attribution is impossible. In using the Nazi data, physicians and scientists are pursuing their own moral commitment to aid patients and to advance science in the interest of mankind. The use of data is predicated upon that duty, and it is in seeking to fulfill that duty that the symbolic significance of that action must be found. I think this point may in fact be ethically conclusive in justifying use of the data when medically or scientifically otherwise indicated. I won't enter into the question of whether it is or not. I will conclude, well, I won't quite conclude. I will almost conclude with an illustrative anecdote concerning one scion of the Soloveitchik rabbinic dynasty who had permitted violating the Shabbat, violating the Sabbath, on behalf of a mildly ill Jew. Upbraided by his students for having issued such a permissive ruling of Jewish law, he responded that in his decision he by no means was taking the laws of the Sabbath lightly. Rather, he was taking the conflicting duties of pikuach nefesh, of preserving life and health, very seriously. One last word. This was difficult for me to work on. I think this has been difficult for all of us to do. I'm particularly disturbed in hearing my own echoes, in hearing myself speaking coldly and logically and analytically about this kind of issue. Certainly there is room for other points of view. I think I have been told that I have no right to talk about these things as a philosopher. A philosopher has no right, a bioethicist has no right to address these kinds of issues. I don't know who does have such a right. I agree that I don't. I think perhaps a survivor may have such a right. I think certainly a survivor of the experiments has a right to talk about them. I certainly don't believe that I have a right. I believe that I have a duty to talk about these things and to try to make sense of them for myself. And I think that each of us in this room has a similar duty. Thank you.
Our next speaker is Susan, and Susan, I'm going to mispronounce it. Seiler Vigorito, thank you. Seiler Vigorito, who is a teacher of Judaic Studies in Cleveland and an officer of CANDLES, which is a organization for survivors of concentration camp medical experiments. Susan, it's a pleasure to welcome you. As she comes up, may I ask everyone to take off your badges? Apparently we're reflecting out the television cameras.
As I've gone on from hour to hour, listening to the various speakers, the physicians and the scientists, it's begun harder and harder for me to prepare for my own talk. Although I'm a practice speaker, I'm almost speechless. I feel I have sat in a room of sterility, a room that is totally unrelated to the world that I lived in. The experiments, the tortures that we're all talking about, are the very tortures that killed my sister, are the very tortures that were done on me. I know that world. I'm a graduate of the school of that world. Terminology such as prisoners, experiment, non-consenting, data, questionable means are such sterile words, completely evading the real issue. Because after all, the real issue here at hand, people, is the evil of the method from which this data was derived. I have no opposition to the use of scientific data, but the method is as much a part of this data as the data itself. The actual methods have been covered up by such sterile words. For example, let me review prisoner. What is a prisoner? We think a prisoner is a common criminal, maybe a murderer, a thief. Not a person who has been starved, beaten, injected with poisons for the mere fact because they are a Jew, or because they are a gypsy, or possibly because they had the courage to stand up and say, this is unjust. So you see, the meaning of the word prisoner takes on a totally different picture. Data. What is data? Data is a list of facts or a listing of process. It doesn't tell us anything about the evil of what happened in the Holocaust. This is what we have to confront. The Holocaust was intrinsically evil, without exception. The use of data in whatever degree will give a degree of credence to the outrages of the Nazi doctors. And so the human torture administered by Dr. Mengele and his compatriots will not, after all, become so evil after all. In Nuremberg, it was resolved that any good that could possibly come from the data, if it were left for scientists to use today or in the future, might possibly prepare a temptation for some future scientist to repeat the horrors of the Holocaust. We have to confront the evil of the Holocaust. I find it not difficult at all. After all, I was there. But you will never understand. If searching for understanding of this evil, in finding that you can't come to that point, and thus you believe that the absolute intrinsic evil of the Holocaust was not there, please be humbled with my statement. It's beyond your ability. It's beyond the ability of the human mind to comprehend the evil of the Holocaust without having been there. And having been there does not lead to understanding. I only know the fact. You're the scientists and the doctors. You need to come to a point of humble acceptance of an era in time that was totally evil. For a person who is accustomed to proofs and negations, this, I realize, is a real challenge. I am not just standing up here and responding from a gut response because I was there. For the last 5 years, I have delved into the issue of the Holocaust with my heart and soul. My academic training has all been a response to my experience of the Holocaust. My first degree in philosophy was to attempt to answer why. My second degree in theology was to attempt to answer why from another direction. My third degree in Judaic studies is to attempt to answer why and understand. I have searched and searched and searched for understanding. So I am not just answering from my own personal experience. I'm answering from a deep searching of my heart. If we use the data, and at the same time, say we make a compromise and we say that all scientists and physicians using the data must also, however, be educated in the horrendousness and the heinous methods in which this data was obtained, and under this condition, the scientist can use the data. Might I just express myself in ordinary language? It sounds to me like you're saying it would be the same thing as saying to your child, you may play in the street, as long as you look at that picture over there of the child run over. It's a contradiction in terms. It's against the very nature of man. If we use something that is evil, somehow or other, we are left with an impression. It can't be intrinsically evil. It can't be totally evil. I want to read, because I, too, have a very short period of time, I think 5 minutes, and I only have 3 left, so I have to cut myself down also very short, but I think I have a little more time tomorrow. I want to read an excerpt from Dr. Nitzli. Dr. Nitzli was a Jewish doctor who became Dr. Mengele's right-hand man. He worked under force. He was a pathologist. But I think really what needs to be done here, the message needs to be driven home. No fancy words, no evasions. From the notes of Dr. Miklos Nitzli. Something occurred here in Auschwitz which was unique in history of medical science in the entire world. 2 twin brothers die together, and at the same time there is the possibility of performing an autopsy on them. The victim is installed in a dentist chair. 2 prisoners hold his hands, and a third bandages his eyes and immobilizes his head. Then the doctor steps forward and plunges a needle into his chest. The victim doesn't die immediately, but everything goes black before his eyes. The other prisoners who had been present during the injection lead the half-conscious victim into an adjacent room and leave him on the floor. He succumbs in less than a half minute. Data is recorded. Another. 1 twin is taken with the help of assistant, is restrained flat on a long cold table. Dr. Mengele approaches. An assistant covers the face. Without the use of any anesthetic, Dr. Mengele opens the child's left leg along the shin. He begins to scrape at the child's shin bone. The pain is excruciating. Somewhere, the child ceases to react. She disassociates. The child is thrown back into a cage. Gauze-like bandages are on her chopped-up leg. Her tuberculin Her tuberculosis acts up. The child coughs, passes out. The victim was tubercular, had been denied any proper nourishment, received nothing for pain, was in trauma. The data from such a series of torture can only destroy the dignity, respectability of science. This data I read off to you is accurate. It was my personal experience. Please think deeply about this question about the use of data. It isn't tainted data. It isn't questionable data. Something that's questionable is something that could be good ethically. It is intrinsically evil. Thank you.
Dr. Velvel Green is a professor of epidemiology and director of the Lord Emanuel Jacobitz Center of Jewish and Medical Ethics at Ben Gurion University in Israel, and he is the next on our panel.
It was difficult to prepare, and it's getting more difficult to talk. And one can't speak after Susan spoke. And what we should do is turn the seats over and sit on the floor and recite the Lamentations. But there was something else that I learned today. And I must say it simply because I come from a country where we speak up, unfortunately, and unlike Minnesotans, we don't always stand in line. Dr. Pozos, get out of this business, please. I was sickened and appalled. I was hurt. It was nothing more than a justification or attempt at a justification of something that can never be justified in your life or mine. That's not the issue. I was going to speak about the problem that was tearing me apart, about the philosophical question of using these data, and about the practical question as a research scientist who worked for many years at this same institution, for close to 30 years at the University of Minnesota. And I was one of the people who was involved in biological warfare defense systems. And being made aware of some of the data that were produced in the Nazi camps, I can assure you that they would have been of great use in the 1960s when we were doing this work. And so I was torn completely of how do you go. And as I told Dr. Kaplan, what night am I speaking? And he said, Thursday night. And I said, Thursday night, I'm against using the data, because Monday, Wednesday, and Friday, I'm for using the data. And it all depends what happened before, because it's that kind of a question. So when I have that kind of a question, I go and consult my sources. I go and consult the rabbis who are experts and knowledgeable in the codes and in the Talmud and in the responsa. And though they told me that there was no specific answer to the question of using Nazi data, there's no question about justifying them, Dr. Pozos. I don't care if the patient screamed or didn't scream. I don't care if only some of them died. In fact, I suggest, sir, that the particular recording of your particular presentation be shown along with Dr. Seidelman's presentation this afternoon once a year in every medical school in the world to show that what Dr. Seidelman said is absolutely true. But that's neither here nor there. I went to speak to my rabbis. And I said, what shall I do? And they said, there are several principles in Jewish law. There are several principles in Torah which are absolutely applicable to this question. He says, you won't like the answer, but these are they. Number one, the principle that has been mentioned by Dr. Friedman and mentioned by Rabbi Weiss. The foremost guiding principle in medicine, in Jewish law, is pikuach nefesh, the saving of a life. Nothing at all stands in the way of saving a life except for the three prohibitions against adultery, idolatry, and murder. Those are the three things that one cannot do. Every one of the 610 other commandments must be put aside, completely put aside, in order to save a life. Number two, because he or she has the ability to save a life, a doctor in Jewish eyes is given certain types of privileges and perquisites. The doctor is the one that makes the decision. The doctor can consult the rabbi, but ultimately the decision as to whether it is life-saving or not and indeed whether the data are pertinent or not are going to belong to the doctor. The doctor is considered in Jewish life as nothing less than the agent of the Almighty in the healing process. And as a consequence, the data themselves, once having been produced, not only may be used, but if in the doctor's opinion can save a human life, must be used. Because Jewish law distinguishes between something that must not be done and something which has to be done in the past. There is a classical example of this in the Talmud. If I am treating a patient and I do not have the therapy, and the therapy belongs to you, and you won't sell it to me, or you won't give it to me, I am not permitted to steal it from you. But if you steal it, or you steal it and give it to me, I may use it. Because the deed has already been done. And to stand there with the therapy in my hand and to say to someone else, I can't use it because it was obtained 40 years ago immorally, illegally, unethically, criminally, is to say, you must die because someone else has suffered. That's not Jewish law. There's even a more important prohibition in Jewish law, and that's benefiting from the dead. One must not benefit from the dead. Contrary to what the pathologists in both Israel and the United States say, autopsy in Jewish law is forbidden except for some very specific circumstances. And the circumstances are when the doctor will learn something or says he will learn something from that autopsy that will benefit the person who needs that information immediately, or a community that is faced with a contagious disease which the autopsy might help to postpone or to evade. Nonetheless, the rabbis told me, doctors who do autopsies illegally and immorally, and they should be excoriated, and they should be excommunicated, and they should be punished, but since they've already done the autopsy, they've learned something, and you cannot expunge knowledge. And that doctor who has learned something is still the agent of the Almighty in the healing process, and must and will contribute to the help in the future. So that in the short time available, in matters of life and death, the data must be used. In matters which are not immediate, in matters where there's a potential but a delayed benefit, in the case of advancement of knowledge, it is up to the research scientist, the physician, the experimenter to decide honestly, will this information have some potential benefit? Now, I was going to say that there are slippery slopes in this argument too. I worry very, very much when I smell burning books. I worry very, very much that the books we are going to burn now are the books from Nazi Germany 40 years ago. And soon we might burn some of the books from Chile, and probably from South Africa, and perhaps from Israel, and perhaps from Iran, because we have many constituencies in the world who have their own pet hates. And though these other places did not do Holocaust, I worry very, very much about setting a precedent for banning data which are already available. I worry very, very much with committees and commissions interfering with a doctor's God-given obligation to heal. I worry very, very much about the promotion for the sake of forgetting, or for the sake of denying or making ourselves feel comfortable. As Dr. Katz said yesterday, they suffered, maybe we should suffer too. I worry very much about giving that to committees to decide which information should be sealed and which information should be available. And I worry most of all about rewarding in our society the devious and the criminal and the unethical scientist who will get to this information nonetheless. My conclusion, very much like the conclusion of Dr. Proctor today, it is not a question of can we use the data. It's a question of how best can we use the data to provide the memorial. Benji Friedman said that. The Torah enjoins us no less than twice, remember Amalek. Remember, we put days aside to remember. And this might be the method. I say again, I think that in every medical school and in every clinical conference, and in every research meeting, this Holocaust must be brought forward. This is what can happen. This is what did happen. This is what happened in our lifetime. And maybe by memorializing in the literature and in the medical schools and in the research conferences what actually happened, we will never mitigate it, but we will remember.
Dr. Nancy Siegel is Assistant Director of the Minnesota Center for Twin and Adoption Research here at the university, and a member of the Department of Psychology. Nancy?
Thank you. I'm going to begin by telling you a little bit more about the twin children who survived the Holocaust. And in particular, I will share with you some of the views of those twins who underwent experiments, but unfortunately could not be here with us this evening. As you know, the twins were the victims of a series of very brutal and very dehumanizing experiments conducted by the infamous Auschwitz physician, Dr. Joseph Mengele, between the spring of 1943 and January of 1945. It's been estimated that 1,500 pairs of twins passed through the camps during those years, and of that number, approximately 157, representing both intact and non-intact twin pairs, have been identified. Perhaps 110 have been found to this date. The twins were the children and young adults from all over Europe, and in January and February of 1985, a reunion took place at Auschwitz, and following that at Yad Vashem in Jerusalem. And if you look to your right, you'll see a slide which shows a number of the twins who gathered there at Yad Vashem. In Jerusalem, there was a 3-day public hearing held, and during that time, we heard testimony from 30 twin and non-twin survivors as to the experiments that took place. And their statements were heard by a distinguished panel of historians, attorneys, and medical geneticists. To provide you with a brief sampling of the experimentation, there were blood transfusions that occurred between twin pairs, exposure to X-rays, extensive body measurements, and the injection of one twin with a noxious substance for later comparison with a co-twin. Susan Vigorito has already read to you a selection from the work of Dr. Neatsley, and I'm going to read you another. Here it was a question of comparing the twins' healthy organs with those functioning abnormally, or of comparing their illnesses. Since it was necessary to perform a dissection for the simultaneous evaluation of anomalies, the twins had to die at the same time. So it was that they met their death in the B section of one of Auschwitz's barracks at the hand of Dr. Mengele. This phenomenon was unique in world medical science history. I'm going to give you one personal story of a man, Mr. Ephraim Reichenberg, who lives in Beersheba, Israel, because it illustrates a very important point and one that we need to consider in a discussion on the use of Nazi data. Mr. Reichenberg came to Auschwitz with his family from Budapest, and when he got off the train, he was accompanied by an older brother. And he shared considerable physical resemblance with that brother, as ordinary brothers often do, but they were not twins. But Mengele's doctors, who were located on the ramp, identified these two brothers as twins, and despite their protests that they were simply ordinary siblings, they were brought to the twins' barracks. And the Nazis wanted to know why one member of a quote-unquote twin pair had a lovely singing voice while the other one did not. So substances were injected into the neck of one of the twins, causing painful swelling, difficulty in breathing. And these symptoms recurred in 1967, causing removal of Mr. Reichenberg's vocal cords. And as you can see in the slide, he's speaking with the assistance of an electronic device, German-made. The point here is that he and his brother constitute what we call a pseudo-twin pair. Their care was not taken to identify real twin pairs all the time, and we know of at least 3 other pseudo-twin pairs in those experiments, There might have been more. The panel at Yad Vashem concluded, as did I, that there was no scientific things. It's been said that they were fed a little better or treated a little better to be kept alive a little longer, but this was simply for the purposes of experimentation, and ultimately they would die or one would be killed following the death of the other, as explained by Dr. Needsley. Finally, we know that some of the data were simply incorrect, and to cite another example that was told to me by one of the twins. He said that as an 8-year-old child, he was asked about the history of twinning in his family, and he didn't know what it was and made up a number, and this number was recorded. The question of, do we use the data? And let me here share with you some of the opinions of some of the twins. Let me preface these remarks by saying that with the assistance of one of the Israeli twins, I was able to pass out a very brief questionnaire to some of the twins living in Israel and in the United States. It was a very general question: should we use the Nazi data? Yes or no, please comment. And I wanted it completed by twins who had actually undergone experiments. I've received only 12 in return. I don't know how many twins have actually received the questionnaire, decided not to complete it. I don't know how representative the sampling is, but I believe the survivors have a right to be heard. Overall, about 2/3 of the 12 feel the data could be used, and they're talking about the data collected at Auschwitz. If it could help humanity, they say, it could be used. They go on to say that if it could justify their suffering and the suffering experienced by their family members, they could see some reason for its use. And let me actually read to you some of their comments. If the information is used for the good of science and for the good of humanity, then I am for it. In contrast, another twin writes, as much as I am for scientific research for the betterment of humanity, I do feel that the scientific data collected from experiments done on inmates of Nazi concentration camps should not be used. If I would agree, I feel I give a stamp of approval to the ways and means these experiments have been conducted and quasi-legalize it. Some of the twins have other concerns. As we've already told you, many were injected with substances, the identity of which is unknown, and they wonder if their current medical and physical difficulties might be linked in part to the treatment they received at Auschwitz. Or are their medical difficulties part of the normal process of aging? One doesn't know, and physicians don't know how to treat them. So one twin writes, it appears that at least in some cases there was an attempt to induce illness by injecting bacteria, and then an attempt to cure these illnesses. That is to say, we served as laboratory animals in the hands of the criminal Mengele, and this type of research should of course be made available to the world. This next twin talks about the use of data and raises some concerns that have been raised here at this conference. Unlike the hypothermia experiments, there are no conceivable circumstances under which the Mengele type research could save lives. Nevertheless, if someone insists on using these results, the victim should only be acknowledged collectively, but not identified by name. It is imperative that the Kaiser Wilhelm Institute be implicated as the initiator and recipient of the research data. It should not be able to get away from the ultimate responsibility for these horrors. In closing, I want to fulfill a promise I made to one of the Israeli twins in return for her assistance in helping me to get these responses. A major concern of the twins concerns the death of Dr. Mengele. Did he really die? And the twin wrote, please make sure that at the meeting you call for the truth about Mengele's death to be revealed. It will be a small moral payment that will lift our spirits, and we will know that today's world hasn't forgotten and abandoned us. Thank you.
Dr. Peter Rossell is Professor of Medical Ethics and Philosophy of Medicine at the University of Copenhagen in Copenhagen, Denmark, and he's next.
Thank you. I'm trying to answer the question whether scientists can use data derived from the concentration camps. And I think that my answer to this question is that scientists can use these data, refer to such information, given that certain conditions are met. And one such condition is, I guess, quite uncontroversial, that these data, this information, have a scientific quality, that is, that they conform to certain standards. And I will say that this is the dispute between Dr. Posel and Dr. Berger, whether or not these data has any kind of scientific validity. But if, however, this is the case, then one has to realize that not just pseudoscientific, but scientific experiments were done on the inmates in the concentration camps. And then the question naturally arises, by accepting that some of these experiments, for example, the experiments on exposure to extreme cold, were good research performed by well-qualified physicians, does this acknowledgement confer any kind of respectability on those who performed and or planned these experiments? And I think that the answer to this question can only be a yes, if one has a very, very narrow conception of respectability. If the respectability of a piece of research or the respectability of a physician or scientist is tied only to a purely technical sense of a good, to a purely technical sense of good. But such a conception, in my view, is too narrow. And one has to confront, I guess, the central issue, that good research, in a purely technical meaning of good, can be, morally speaking, totally unacceptable. I guess that this is one of the central, although perhaps a trivial point, but a point, I think, it has been very hard for some scientists to accept. And I guess that this has been one of the reasons why these experiments has been called either pseudoscientific or the word scientific put in quotation marks. Apart from being of a good scientific quality, if there are others, did these experiments generate any information or practical value? For example, information to the preventing of death from exposure to cold. And as far as I can see and I can tell from what I have heard, it seems to be the case. And then we have to ask a further question. Does using this information today to save lives doesn't mean that one must accept that good in a moral sense can come from evil? And I guess that we have to realize this, but also to be in mind that a common defense by the physicians during the Nuremberg trial was a kind of a moral argument, that the ends justified the means, that the goal of saving many lives justified the means, the infliction of pain, suffering, and even death of the unconsenting few, the inmates who were the subject of this research. And Professor Karl Gebhardt, among others, argued this in this way. But I also think that it should be made clear that the fact that good may come from evil doesn't imply that one subscribe or endorse the notion that the goods end of research justify the means. The violation of the humanity of the inmates, for example, their autonomy and integrity. The inmates were just used as means, but I also want to emphasize another kind of argument used by physicians during the trial, that they, the doctors, and it was one of the arguments that Arthur Kaplan did mention, that they, the doctors, were just instruments in the service of some higher ends or goals. Karl Brandt, for example, used this argument to deny any kind of personal responsibility. So, not only the inmates were used as mere means instruments, but also some of the scientists perceived themselves as mere instruments, thereby violating Kant's famous dictum of never treating humanity in your own person as well as in others, merely as a mean, but always as an end in itself. As I see it as both as I see it in this way, that the inmates were treated just as means, in a certain way, as instruments. But I also think that some of the physicians, the scientists, saw themselves as just instruments in the service of some higher goal, however perverse it may be. And I certainly do not want to trivialize those horrors that went on in the concentration camps by making references to human subjects research today. But I think that one moral lesson from the Nazi research is that scientists should not see themselves as depersonalized instruments in the pursuit of good ends. And this brings me to my final point. By using this information today, will that encourage doctors to show less respect for those involved as subjects in human experimentation? And I think that this is an empirical question. We simply don't know. But in order to prevent this, I think that any reference to those data, any citation, should include a statement about the circumstances under which they were attained. In fact, I think that the use of this information should or could encourage scientists today to show not less but greater respect for those involved in human experimentation, by making the scientific community realize that good research in a purely technical sense of good is only a necessary but not a sufficient condition for the moral acceptability of research. That although good may come from evil, this doesn't imply the endorsement of the maxim that the ends justify the means. And finally, the scientists should not see themselves nor their subjects as depersonalized instruments or means in the service of some goal. And I have to finish soon, but I will say that 10 years ago, I went through the documents from the Nuremberg trial. I wrote a book about medical ethics. And the last chapter of that book is about the Nuremberg trial, the way the physicians defended themselves during that trial. And I will also say that I confronted the ghost of the victims. And the last comment I will make here is that in Denmark, I have very much teaching of physicians, postgraduate physicians, and I always start my teaching in the ethics of human experimentation with a deep discussion of the Holocaust, in order to try to prevent that those horrors in any degree should happen again. Thank you.
Eva Kor is our last presenter. She is founder and president of CANDLES, the Organization for Survivors of Concentration Camp Medical Experiments. Eva?
Thank you very much. The organization's name is CANDLES, Children of Auschwitz Nazi Deadly Lab Experiment Survivors, which are the twins. I would like to apologize to all these distinguished people. I am the troublemaker. You had to cut your speeches because of me. I have been an all-time troublemaker all the way from Auschwitz. I gave trouble to Mengele there too. And I'm not going to change now. Dr. Pozo, watch out. Dear friends, thank you very much for the opportunity to speak to this important forum, and my special thanks to Dr. Kaplan. I will discuss 3 different topics that all will relate to the suffering, what actually happened to the victims as happened to me, what did we do afterward, which would be the life after the liberation, how did we cope with the disease and the trauma, and the last is the Nazi data, what should be done with it. When I arrived in Birkenau with my family, my twin sister and I were torn away from my mother's arms and became part of 1,500 sets of twins used by Mengele in his many experiments. Our day began with roll call at 6 a.m. in the morning, summer, winter, rain or shine. An hour, sometimes 2 hours, and on one occasion a whole day. The roll call was going on until every person was accounted for. Then we returned to our barracks, where every day we were inspected by Dr. Mengele. He was accompanied always by another doctor who is living free, Dr. Hans Koenig, and usually 6 other people were in his entourage. He moved about, nervously pacing and counting us, while snapping a little riding stick against his boots. If there were any dead children in the barrack, he would become very, very angry. 3 times a week we were taken to the blood lab. There they tied both of my arms. On one arm they gave me lots of shots. From the other one they took blood, about 2 vials each time. Once a week we were taken to the showers and given a bar of soap, and our clothes were taken away. We were stripped for disinfecting. It was a fruitless effort in trying to get rid of the lice that we were infested with. 3 times a week we were taken to the Auschwitz I lab for experiments. These would last from 8 to 10 hours. They would strip us naked and put us in groups of 10 to 12 children in a big room. Every part of our body was measured, photographed, marked, and compared to charts. Every movement we made was noted by scientists. I felt like a piece of meat. These experiments were emotionally very difficult to deal with, but the deadly ones were the one in the blood lab. In early July of 1944, I was injected with some kind of a germ. By evening, I became extremely sick. I had a very high fever. I was trembling. I had difficulty standing or thinking. On my next visit to the lab, the doctors did not tie my arms as usual, but checked my fever. I was desperately trying to hide the fact that I was ill, because there was a very well-known rumor that anybody who was taken to the hospital never came back alive. Well, my fever was checked, and they found out that indeed it was extremely high, and I was sent to the hospital. Mengele came to see me twice a day with 4 other doctors. They checked my fever chart, but never examined me. I was given no food, no water, no medication. I was in the barrack of the living dead. One of them said sarcastically, "Too bad, she has only 2 weeks to live." But I was determined to get well and be reunited with my sister. I now know that if I would have died, they would have killed my twin sister Miriam with a final shot to her heart. Then Dr. Nisley would have performed the autopsies on the 2 bodies. I remember waking up on the floor, fading in and out of consciousness. I was crawling to the other end and trying to reach a faucet with water. After 2 weeks, my fever broke, and within 3 weeks afterwards, I was reunited with my sister Miriam. We were liberated on January 27, 1945. I'm going to the Topic number 2, what happened after liberation? After liberation, I thought that my problems would be over. For 9 months, we were in DP camps, displaced person camps. In late September, we returned home. No one else from our family has survived. The first year back, we were covered with boils and blisters from malnutrition. In May of 1946, we went to the first memorial service to the Holocaust. The rabbi asked us to bring any soap from the camps for a special burial ceremony. At that time, I learned that the soap that I washed with for 2 years was made out of human fat. I had nightmares that I washed with soap made out of my own parents. They did not stop until 1950, when we emigrated to Israel. In 1960, I married an American tourist and came to live in Terre Haute, Indiana. Miriam was already married and has just had her first baby. Then she became very ill with kidney problems. After many tests, they found that her kidneys were the size of a very young child, and because of the burden with the pregnancy, they were not functioning at all. In 1987, she became so ill that she told me that she needed a transplant in order to survive. I told her that I would be the donor. So on November 16, 1987, I gave her my left kidney. We were a perfect match because we were identical twins. She was fine for 1 year. Then she developed cancer polyps that came from the anti-rejection medication combined with some kind of a strange substance in her body that was already there for some time. If they could find our files from Auschwitz, and Dr. Pozo, maybe you really want to help us, it might help the doctors find a cure for her. Regarding the Nazi data, I am absolutely appalled that anyone wanting to validate the Nazis by using the data collected by them. In Auschwitz, we were treated like a commodity, the living and the dead. The hair was used for mattresses, the fat was used for soap, the skin for lampshades, the gold put from the teeth to go into the Nazi treasury. Now, today, doctors want to use the only thing left, the data left by the Nazis. Is this to further their own professional ambitions? That seems so wrong to me that I can't find strong enough words to express myself. The data from the twins experiment should be given to each twin who is alive, and for those who have died, the data should be shredded into pieces and placed in a monument to bear the inscription. This is to remind the world that no human being should ever be used in experiments. That was going to be my finish, but because of Dr. Pozo's speech, I cannot really finish with that. I am appalled by you, Dr. Pozos. I am absolutely appalled. I don't believe that you have the courage to
Thank you, Ron. I'd like many others before would like to add my note of thanks and praise to Arthur Kaplan for putting this conference together. It is a rare event, too rare, I think I agree with him, on a subject that deserves a lot more attention than it's gotten. I will comment on both Professor Proctor and Professor Mueller-Hill's presentation, but mostly I think my brief comments will be a footnote to those of Art, Jay, and Ruth, my colleagues in bioethics. And what I plan to do is not talk about Germany, since I don't know very much about Germany, and certainly not as much as the last two speakers, but to talk about the culture I know something about, which is our own, and to try to think about what forces are at work in our own culture that we really need to guard against in order to prevent, probably not the magnitude, but the types of desecration of human beings that took place in the Holocaust. Shortly after World War II, there were two different views futurists had of the United States. One was George Orwell, who viewed the major problem that we had to cope with as being totalitarianism, National Socialism being the primary example. And his view of the future was a totalitarian government that told people what to do. Huxley, in his Brave New World, saw quite a different future for us. He saw the future as being one not in which individuals had to be forced to do the things the government wanted it to do, but in which individuals would do these things voluntarily and eagerly, in which individuals would be manipulated to want the things that made sense from the government's point of view. It seems to me in the United States that we're much more likely to want to do things that appear to us good for ourselves and good for the society than we are to be victims of a totalitarian regime. And what I've learned so far from this day and a half that we're into, which I think is correct, is that while racism and sexism are necessary in order to lead to the types of abuses we've seen, they're not sufficient. They're not sufficient. And certainly our society has plenty of racism and sexism. I don't think we have to discuss that. That we need more. The Nazis had the government, National Socialism, and a racist ideology to go with it. What forces do we have in the United States that are of anywhere similar to that? Well, I'd like to mention three, and then give you an example from, obviously, our topic today, racial hygiene or eugenics, that may illustrate problems that we have right here. The three forces at work I want to talk about are Ruth Macklin's force of economics. Second force is our penchant to deny death and think of it as the worst possible thing that can happen. And third, and probably the most powerful force at work in the United States, is commercialism and its handmaiden hype. Let me talk about each of those quickly. First of all, economics. I think probably the most eloquent statement of our view of economics is this one. We have seen more than once that the public welfare may call upon the best citizens for their lives. It would be strange if it could not call upon those who already sap the strength of the state for those lesser sacrifices, often not felt to be such by those concerned in order to prevent our being swamped with incompetence. It would be better for all the world if instead of waiting to execute degenerate offspring for crime or let them starve for their imbecility, society can prevent those who are manifestly unfit from continuing their kind. As you probably know, that's not from any Nazi racist. That's from the United States Supreme Court. That's Justice Oliver Wendell Holmes, writing in 1927, for a court that was split only 8-1. Only one justice dissented from that. And that opinion has never been repudiated by our own Supreme Court. Indeed, as recently as 15 years ago, it was cited as authority by our Supreme Court. The second statement, human mating that proceeds without the use of genetic data about the risks of transmitting diseases will produce greater mortality and medical costs than if carriers of potentially deleterious genes are alerted to their status and encouraged to mate with non-carriers or to use artificial insemination or other reproductive strategies. Well, obviously that's not from Germany either. That's from a book written by the Office of Technology Assessment of the Congress of the United States way back in 1988. So these forces are very much part of our culture, to look at individuals who we think do not have sufficient genetic material and who cost us money as a problem to be dealt with, either by compulsory sterilization, as in the 1920s and 1930s, or by encouraging them to mate with non-carriers and use artificial insemination or other reproductive strategies in 1988 and 1989. Efficiency is obviously the watchword for us and for economics. Cost-benefit analysis has been mentioned before. But we could also mention that efficiency is the key to patients' rights in this country, and especially informed consent. I have talked to a number of physicians at this conference about informed consent since Dr. Katz's speech yesterday, and they have said, as many physicians have told me before, you know, people can't really understand this information. They really don't want to know about it. After all, they can't be objective about their own health care, and it really just spends a lot of time. Doctors' time should be much better spent doing procedures rather than explaining procedures. There's a trivial example of that right here in this conference. I'm sure Art will forgive me for this example. There's a sign, which probably most of you didn't see, just before you enter this hall, that says that entering this hall constitutes your consent to be taped, to be put on videotape. Well, that's a funny way to think of consent, but obviously that's the way we do think of consent in this country. It's like, it's just something we tell people about. It's, don't take it seriously. Obviously, none of you, you're all here in the hall, obviously. I can ask you whether you think you consented to anything by coming here except to listen to people, but you'd obviously stand up and leave if you don't like what they say. But it's efficiency that rules that. We could have given everyone a consent form to sign and explain what videotaping is. We could have even had a special section in the back, maybe, for people who didn't want to be photographed, and the cameras wouldn't photograph you there. But all of that would take more time and would be less efficient. And so, for the purposes, and with apologies to the person who said this today, this conference room has been structured to serve the purposes of TV production. In the United States, that is not unusual at all, by the way. TV production may be our highest value, actually. And I think we know that. We may have felt differently if we were going to be screened for blood pressure or for cholesterol levels or certainly for drug use, but we don't feel bad about being on TV, in general. All right, so economics and efficiency are very important values. The second value is denial of death, and I don't even think I have to make that point. Art made it beautifully, I thought, when he asked a number of times how we use the phrase the Nazis used, that these people are doomed to die anyway, and therefore it's okay for us to experiment on them. You don't have to look far for an example in the United States. You look at today's Star Tribune on page 22, an article talking about the genetic experiments just approved in the United States yesterday, as you may have read, about the first genetic engineering done in the United States. Who will it be done on? Terminally ill cancer patients who have less than a month to live. Will it benefit them? Well, of course not. But as Jay Katz pointed out yesterday, we'll tell them that it might. In fact, the article says, quotes the consent form, these patients have accepted a consent statement saying that although the experiment is not expected to improve your therapy at this time, quote, it is also possible that it may lead to improved cancer therapies for yourself and others in the future, end quote. Well, the truth of the matter is it is not possible. This is not a therapy, as the article makes clear, and as other articles about this study have made clear. We're just looking for markers that we can test future developments of future therapies on. But we feel for some reason that we have to tell people that we might help them, and I've talked to many cancer researchers who feel this, that they can't say in their own mind, they can't do this phase 1 research without thinking it might help someone. And number 2, we feel we have to do the research on people who are dying, because they, after all, know there's no risk to this research, but maybe if there is, at least they're dying anyway, so it's okay. And we all as a society feel comfortable about it because we think maybe it will prevent us from dying. So the second is denial of death. The third is commercialism. I think this is the most pervasive in our society, the ideology of the market, and that commerce and the market and the free market is what makes us a great nation. You all remember the Apollo Moon Project, which we said, and the hype was that was about peace. The plaque we left on the moon was that we came in peace for all mankind. As Walter McDougall has pointed out in his brilliant political history of the space program, that the Apollo moon program was not about that at all. It was about militarism and commercialism. It was about, and we've certainly seen that since then, and that it was the cover story that we were doing this for mankind that made us feel comfortable. All right, now let me take the example that we're using today, which is genetics, and see how it fits into what is actually occurring now, how we feel about it. The project I want to talk about is the Human Genome Project. Professor Hill mentioned it briefly. Talking about when we get DNA, the Nazis in the 20s and 30s really didn't know what they were talking about. Now that we have DNA, and we can map the human genome, figure out the 3 billion base pairs that make a human being, then we'll know what's going on. James Watson, who was just appointed to head our Human Genome Project last fall, said last month, quote, "I see an extraordinary potential for human betterment ahead of us. We can have at our disposal the ultimate tool for understanding ourselves at the molecular level. The time to act now is now. Quote, again, our fate is in our genes." Well, obviously he wasn't studying history before he made those comments, but his enthusiasm, I think, is real. He really believes what he says. The hype, the commercialism in the United States meant that the Wall Street Journal would editorialize about this, and they did. They talked about biotechnology today affording mankind the potential to relieve the scourges of many diseases and infirmities. And then what's happening in the world? Well, Europe wants to get involved in the Genome Project. So the Wall Street Journal says some members of the European Parliament are already saying that the project isn't being sufficiently regulated, that there are all sorts of questions to answer about ethics and misuse, that these questions of ethics ought to be answered before the project proceeds. Well, what does the Wall Street Journal think of this? This, of course, is a formula for making no progress at all. All right? We should answer the ethics questions when the project is done. There's no point to answer them before, and we've saw that with the Manhattan Project and with other scientific projects. The National Institutes of Health has put out a funding proposal for ethicists. And I've talked to many of my colleagues around the country who are not quite slobbering, but are ready and willing and are putting in funding proposals because the Genome Project, which will be funded by eventually billions of dollars, has planned to put 1 to 3% of their money into ethics. Now that's really important to do that. But what kind of ethics are they going to study? The funding proposal from NIH, just came out 2 months ago, says the plan to map and sequence the entire genome is predicated on the belief in the immense potential benefit to humankind of the information to be gained through the advances in medicine, biological research, and biotechnology. The prospect of benefit is clear. The only question arises regarding the best way to ensure that the information is used in the most beneficial and responsible manner. Not even a thought that there might be any problems or that there may be any possible dangers in this proposal. Ethics are just supposed to look at what's good about it and how the good stuff can be made better. In fact, although it sounds wrong, I think it's probably correct to say, and I have enough bioethics colleagues around here who can take me on this, that the only time we take medical ethics seriously in the United States is when it doesn't matter. That the only physicians, with very few exceptions, and surgeons who take medical ethics, informed consent, and patients' rights seriously are when they can do their research anyway, consistent with it. If they can't do their research, then it's not to be taken seriously. The Human Genome meeting held at Valencia last fall from representatives of countries around the world, Jean Doucet of France, made a motion that there be a moratorium on any genetic manipulation of germ cells, which he said could open the door to Nazi-like atrocities, and he recommended a ban on gene transfer experiments from early embryos. Most of the members there actually thought this was a good idea, but one of the leaders from the United States said that he thought this was terrible, that the last thing we should do is ban anything, that this could have a negative reaction among the world's scientists, and we should go ahead with the research first and worry about atrocities and things that might happen later. That's clearly the main view in scientists. Let me illustrate this with a couple slides very quickly, and then come to a conclusion about whether the Nuremberg Code can help us on this. We do indeed, and as Dr. Muir-Hill said, look at progress as religion. Paul Simon's song last year on the Graceland album, The Boy in the Bubble. That's Baby David, the boy in the bubble. The refrain is, these are the days of miracles and wonders. Medicine is magical. Medicine is art. From the boy in the bubble to the baby with the baboon heart. And we do see medicine as a religion, and we talk about miracles, 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 and we usually pray for a miracle. In the United States, we combine this with commercialism and hype. That's the real Statue of Liberty celebration at the bicentennial, and come out with major articles about the search for the cure, about AIDS, and we'll do anything to try to find these cures. In genetics, test tube babies and in vitro fertilization, combined with a true map of the human genome, will lead us to the potentials in genetics manipulation, in eugenics, never dreamt of before. This is an actual slide of a human embryo being biopsied. This actually can be done today and is being done today. That human embryos can be biopsied, a cell taken out and cultured, it can be karyotyped, and it can be screened for a multitude of genetic defects. Within a matter of decades, some people think within a matter of a decade, we'll be able to sequence the entire genome of a human embryo and then make the decision whether individual embryos should be grown, should be allowed to become human beings. This is not science fiction, this is real. This can be done. Is this a good thing or a bad thing? Well, I don't think we should wait until we have the capability to make that kind of decision. I already know how hard it is to make decisions about handicapped newborns. It'll seem much easier to make decisions about embryos. Could this lead to children being thought of as commodities, as objects to be bought and sold, as objects without inherent value? If so, obviously, one might guess the black child in the middle will be worth less than the white children, that monetary values in our country will be put on intelligence, on height, on eye color, on athletic ability, on whatever things we find marketable. One need not even gestate these children. You could buy the embryos from a catalog and hire a surrogate mother to have the baby for you. That's perfectly consistent with American values. As you probably all remember, after the Baby M trial, before the Baby M trial, actually fully 80% of Americans believed that Mrs. Whitehead should follow her contract because a deal's a deal, and women, after all, are made to have babies. And it's not just a Nazi idea that giving birth is a primary function of women. In the future, we'll be able to take the human genome and actually, by sequencing it, figure out not which defects and which diseases you're going to have, but which ones you might have. That you have a higher probability than other people of developing lung cancer, or schizophrenia, or literally almost any disease that we can find a genetic basis for. How will this information be used? Well, maybe we shouldn't think about it until we have it. One possible way is to try to develop a perfect human being, a perfect genome, a perfect genotype, as if that's within our capabilities. And making babies will then be real. Making babies will then be real. We will literally manufacture children once we're able to do genetic manipulation at the embryo level. We will literally be able to switch genes on individuals and manufacture the type of children that we want. There can't be anything wrong with that. Obviously, Jim Watson must be right. NIH must be right. The Office of Technology Assessment must be right. All these people can't be wrong. We should do this first and think about consequences later. One of the good things I think that came out of the Apollo moonshot was a view of the Earth, and the point of it as being one organism, that we're not all living somewhere else, we're all living here, that we're all members of the human race, and that our job is not to try to figure out how different we are from each other, but to realize how similar we are to each other, and how we're all members of the same race, and how we can foster personhood and human fulfillment and individuality, and not quite the opposite of homogenation and destruction. I think the Time magazine a couple weeks ago did a feature on Alaska after the oil spill, and they called it the Battle for America's Last Frontier. Well, what I'd like to suggest in conclusion is that America's last frontier is really morality, ethics, trying to decide where we're going. Right now we know we're going there. We're going for progress. We're going for things that are new, for things that make money, for things that can be commercialized. As we used to say in the 20s, every day in every way, things are getting better and better. But as we go in that direction, I think the oil-tarred otter in Alaska somehow is emblematic of ourselves. I think this conference, if nothing else, has shown that we're tarred by the Nazis, tarred by the medical profession and scientific profession in Germany, that we can't get out of it until we confront it, and that really is our challenge. And that Hans Jonas, the great philosopher, was right when he said, and Jay Katz echoed this yesterday, quote, that progress is an optional goal, not an unconditional commitment, and its tempo has nothing sacred about it. A slower progress in the conquest of disease would not threaten society, but society would indeed be threatened by an erosion of those moral values whose loss, possibly caused by too ruthless a pursuit of scientific progress, would make its most dazzling triumphs worth having. We should underline that. I've always thought that captured the truth remarkably well, and I've always been amazed at how little attention people really pay to that. People say that and then say, okay, fine, we've said that, now let's go on and do what we want to do. But where are we going? I suggested to a graduating class of public health a couple years ago, and I think it's still right, that if we look at our public health goals now, and we don't look at them well, what we would see as kind of the ideal world from a public health practitioner. I think it's extremely important to note that public health is a government-created mandate as it was in Germany. That the ideal would be a world of mass contentment and mass containment, an Earth-sized human zoo in which every man, woman, and child was fed with the most nutritious food, vaccinated against all diseases, and lived in a clean, germ-free, and pollution-free cages, and were drugged into states of happiness and even euphoria. That really does seem to be our goal today, an antiseptic world in which we all live to be 100 or 1,000, or at least a lot longer than we live today. We really don't seem to have any values. And although we mouth the values of human rights, of equality, of justice and fairness, we don't take them seriously when it comes to science. And it's certainly my hope that this conference will add at least some impetus to some scientists to take values seriously. Thank you.
Thank you, George. Our second discussant is Dr. Richard King, who is a medical geneticist here on the faculty at University of Minnesota in the Institute of Human Genetics. Dick.
The introduction is short because I really feel somewhat out of place here. I'm way out of my league. I am not a historian or a philosopher, and I have spent a lot of time thinking about these subjects, and as I mentioned earlier, from perhaps a slightly different view, but I am a clinical geneticist, a medical geneticist, and I feel very strongly about some of the points that Dr. Mueller-Hill and Dr. Proctor have made in their presentations, because I think they are very much happening at the present time, at least in the United States, in the practice of medical genetics. We are currently dealing with making judgments, or people are dealing with making judgments on individuals as to whether this is a quote-unquote quality type of person or not, in terms of prenatal diagnosis and amniocentesis and other types of prenatal diagnostic programs that are in process. We certainly do genetic screening. We screen couples who may be at risk for specific genetic diseases, obviously with the idea that they would know that they carry a particular disease so that they could prevent the birth of that disease by mating with somebody differently, or by having pregnancies monitored if they in fact are both carriers for a particular condition. So I think many of the things that were described in the processes that went on in Germany, in fact, are similar to what we consider to be ethical and proper medical genetics in the United States. However, I think that there are some fairly major differences, and I'm not one to say really where we are now and how this process is going to continue. But the major difference, I think, is the fact that all of the genetic community as I know it anyway, deals with genetics from the individual standpoint rather than the population standpoint. I think both Dr. Proctor and Dr. Mueller-Hill clearly talked about the population effect of the eugenics and euthanasia programs. In genetics at the present time, we deal with the individual. We try to think that we deal with the individual. And we try and use our information to educate individuals so that they can make decisions. Now, not everybody is going to make the same decision as you may feel you would make, but we want to give the people that we're dealing with the option to make that decision as well as they can. So we feel that our role is that of to educate them and to allow them as an individual to make a decision. We do not deal with the population. We do not deal, for instance, with increasing gene pools in the population. It's clear that there are certain diseases, the gene for Tay-Sachs disease, the frequency of the gene is increased, the heterozygote frequency is increased, the frequency of the gene for retinoblastoma has increased. In some estimates it has almost doubled in one generation because of the fact that we've been able to treat and effectively and keep individuals with the gene alive. So there are clearly population effects that are occurring, but we do not deal with those generally in genetics. And as I say, we have ignored the population situation. Well, or the effects on the population. Now, that's where we are now, and I think the point of where we're going was brought up by our last speaker, and I probably take a different view of the human genome sequencing than he does because I'm involved with it. I want to get some of the money to do it. I think that it's an important project, and I think from my own particular interest, which is the genetic basis of common adult diseases, I think it has a lot to do with how we are going to live our lives in the future. The Human Genome Project is an immense project. The size of the genome is incomprehensible to most of us. The complexity of it is beyond anything that we can even imagine. At noon, I heard a seminar by an NIH researcher who is just studying one single gene, the gene of one of the types of hemoglobin. And we used to think that the control of this single gene would be a fairly straightforward project to understand. And now the complexity of it, including multitude of proteins and multitude of binding sites and changing the configuration of the chromosome when the gene is turned on and turned off, is just beyond anything that we can really comprehend. And in fact, at our lunch afterwards, we talked about our need to theoretically move to another level of understanding, because our concept of how the human genome operates at the present time is beyond our level of understanding. Well, the fact is that the sequencing of the human genome is going to start. It is going to be done, and it raises some important issues that have to be dealt with. And I have been talking about this for some time and talking to our medical students about this, and I think it's pretty much what the last speaker was dealing with also. And that is that we are going to gain information, and we're going to learn about information that we do not know how to handle. We have nothing in our background that's going to tell us how to deal with the kinds of information that we're going to generate. And in fact, we are going to have more information available than presently exists, or we even thought would be able to exist 5 or so years ago. The fact that the NIH has suggested that 1 to 3% of their budget be devoted to the ethical considerations of this, I think is I would take a slightly different view and say that that is a good first start, that in fact, since the project, there is no way that the project's going to be started, at least we're going to start dealing with some of the ethical issues that have to be dealt with. But in fact, they're being dealt with beforehand. We are already able to make pre-symptomatic diagnoses for diseases that we cannot treat. We can diagnose people with Huntington's disease at birth, and we have nothing to do, we can do nothing for them. We know that 30 or 40 years hence they're going to develop a terrible neurological disease and die, and we really can't deal with that in terms of providing any therapy. So we have methods available now, and we will have, with sequencing the human genome, I think, more information that will have to be dealt with. And I would encourage that instead of stopping the project, that we put a very strong ethical component to the project so that they can go along together. We can learn how to deal with this information as the information becomes available. I guess I'm not quite as frightened of stopping the project and having to completely settle all of the ethical issues before we restart the project. I also think that the immensity of sequencing the genome is going to lead to some very unusual relationships. There was an article in Science this week which suggested that perhaps we should divide the chromosomes, the human chromosomes, up by country, and Japan should get chromosome number 1 and 7 and 4, and Spain should get the bottom half of chromosome number 3 because they just get a little bit, and Italy would get a little bit more, but we wouldn't give them a very important chromosome. And I mean, there already are sort of bizarre views of how the project is going to be done, and I think the ethical issues need to be dealt with, and I think are going to be dealt with, at least initially, with the beginning of the project. We estimate that there are approximately 100,000 genes in the human genome. There's a lot of DNA, but there are approximately 100,000 active genes. At the present time, we know about 5,000 of them. So there are 95,000 genes yet to be known, and I suspect that the majority of those genes are going to deal with either development, that is how we end up with 5 fingers and 5 toes and 2 eyes and a nose and things like that, or with the common adult diseases, the diseases that are, in fact, are the ones that the question of nature and nurture has always dealt with. The mental illnesses, the schizophrenia type diseases, the common types of heart disease, common types of lung disease, liver, arthritis, all the common diseases, I think, have there's evidence for significant genetic basis, and we're going to have information on those diseases at the genetic level probably within the next 20 or 30 years. I would think that within that 20 or 30 year period, we should be able to develop some ethical scaffolding to help us maintain this immense amount of information that we're going to have. And in fact, from my viewpoint as an active scientist, I would think that in fact would occur. That would be my view that would occur. So I think in summary or in conclusion, I would say that the process that went on in Germany is similar to some of the activity that is going on now, but the scope of it, the approach to it is rather different. I feel that it's different from my own background, and I think the future of genetics and the application of genetic methodology to understanding both normal and abnormal human development is going to occur, and that I would strongly support the idea that the ethical aspects need to be developed along with the development of the information, but not. I don't think that it has to occur before all of the information is obtained. Thank you.
Please forward your questions to the front. Dick, I wonder if you and George might comment on a practical method for this to occur, for the ethical guidance to occur, for a physician who's practicing on the front lines or a scientist in the laboratory? George, what are your thoughts about what might be a mechanism to provide the ethical guidance that you've talked about?
Well, that, of course, is always difficult. There is an international body of scientists set up to look at the human genome, which has been dubbed they're from 42 scientists. I can't remember from how many countries they're from, but they've been dubbed a UN of the human genome. And I think that's a very inaccurate type of description. Number one, they're all scientists. There are no ethicists, there are no philosophers, there's no lawyers, there are no politicians involved in that. And if we've learned anything else, that science is very insular, that it has its own value system. It thinks it's only interested in the truth, and that it's objective. And that's been proven wrong time and time again. So number one, that model has got to be broken. We thought we broke that model years ago with institutional review boards, but even they only have one person out of 5 has to be a non-researcher. So number one, groups, any group, seems to me now to be legitimate in this world, that thinks it's going to set policy and shape the future of a major technology like the human genome, simply cannot be made up solely of scientists, number one. Number two, groups like that should meet in the open, and the public should be informed of how things are going. I think that was part of the settlement, although I haven't seen the actual settlement yesterday, of the gene therapy trial that Jeremy Rifkin and his group was bringing against NIH, that from now on the deliberations about new genetic therapy in this country will be made in a public forum at least, so people can do that. So I think those two things, number one, broadening the number of people who have input, and number two, making sure that major decisions are made and discussed in public forums so the public can have some input and know what's going on, are the two most important things. I don't want to set up an ethics czar or pretend that ethicists have more knowledge about this than anyone else, but they certainly have a different perspective.
Dick, do you want to comment on that?
No, I think he said it all.
Robert, here's a question from pertaining to your talk. Would you be a little bit more specific? Try to describe the psychological makeup of an individual German physician who participated in the gas chamber killings. How did he or she justify his or her actions? And please provide a profile of his or her value judgments.
Yeah, that's sort of a difficult one. I think the closest thing I might say to that is some of the things that came out in Nuremberg in a way, which is always risky information because that's a series of rationalizations in a way, and I imagine the psychology might have been quite different. People would say things like they were following orders and so forth. They would also say they were working for the greater good by doing experiments, that experiments would help people further down the line. I'm not sure. I know there were selections made of the type of physician who was going to be allowed. For example, Catholic physicians generally were not chosen to be in this area. Generally, physicians were from the SS would be the ones who were chosen. That's probably the best thing. Do you want to say anything on that?
Anybody else want to comment on that?
Just to recommend Jay Lifton's book on the Nazi doctors for a psychological study of those physicians.
Dick, do you think there will be more ethical issues raised with the discovery of genes that control or influence emotions rather than those regarding physical traits?
Well, there are clearly more emotional issues raised with diseases that involve emotions versus those that involve physical traits in general. But so as a generality, I guess I would say yes, that perhaps is going to be so. I think the bigger issue is going to be the issue of defining the norm, not so much the behavior or the physical abnormalities, but what is going to be normal. It's back to the slide that was shown as to be the perfect male and female, or the perfect person. The The real issue is going to be how a norm, if a norm is going to be defined, what is going to be a norm, even in terms of sequencing the human genome to start with. Would you like to be the person to be selected as the one to be the normal one, against which all others will be compared? If we sequenced you first, would that, do you feel that, I mean, I'm just editorializing, do you feel that you would be normal enough to say that, yes, they can compare everybody in the world to me because I'm the world standard? Defining the norm, I think, is going to be a bigger issue than defining the behavioral or the physical traits. It's clear, the examples that I use when I talk to the students, we can deal with individuals who are born with the disease and they are known to die within a day or two, something like anencephaly, where they have born without a brain and they basically are not able to survive because they do not have the neurological tissue available to do it. And we can sort of look at the other end of the scale and say, yes, most, say, college students or medical students or graduate students probably would fit in a category where people would say, yes, perhaps those would fall into a normal category. But anything in between those, and that one on the left, this one down here that I'm saying normal, is a little hard to say right now, but anything in between we don't have any way to say about. And that's where the biggest issue is going to be. People are going to want to say what's normal and what's not normal, and they're going to want to define a norm, and that's going to be real difficult. That has to be addressed.
As a former medical student, I don't know if I'd put myself in that category of normal. Mueller-Hill, Dr. Mueller-Hill?
Comment on that. I think there's another problem which may be even a larger problem. I think if you really think the issue through, and if you take for granted what sounds reasonable, I can give you just, or let me specific. Let's assume the study which showed that schizophrenia, in brackets, is really inheritable and has a particular gene, is associated to a particular gene. Now, this particular study, in fact, showed that, I take it now for granted, even knowing, as I could discuss now some weaknesses within this paper, but let's assume that it is so, yeah? Then, in fact, what the study had shown was that it's not just schizophrenia, but a whole series of behaviors which make apparently the carrier unable to cope with the world, our industrial world as it is. Drinking, drugs, phobias, psychosis, and what's a whole range of behaviors. Now let's assume that this gene is isolated, and let's assume that there's a fast test, which of course once you have it, you can test the variants fast. So then, and again, let's assume that's about 1% to 5% of the populations which are afflicted. Now, what to do now? And my prediction will be, or is, that in fact the world will split into two halves. Those who would like to know what the situation is, the mothers about their unborn babies and about their born babies, of course, and grown-ups about themselves. And even if you just limit knowledge exclusively to the person itself and to the mother and her unborn, still I would assume that some persons, and I would particularly belong to this group, would say that they don't want to know. And I think the world will split in those which will know and which will abort and which will brag that they have the positive phenotype, and those which don't want to know. And I think the most important ethical issue will be, in my opinion, that those who don't want to know get enough protection that they can live. And I think if they don't get the protection, then really something will happen which will be extremely, extremely unpleasant. So I think the most important thing is really to create an area for those people whom I would like to call the religious people who don't want to know, and who don't want to know about the condition of their unborn, who refuse to have the abortion, who simply to leave them alone. Whereas on the other side, I would also say, and I'm for the project, I'm advocating the project. On the other hand, I would like to say that those who belong to the religious category would let the scientific ones go on. And I think the most important thing will be to have peace between those who want to know and those who don't want to know. Very difficult.
George, you wanted to add?
Yeah, and the real question is whether we're going to be able to have that choice. I mean, even think. In industries, and it's very clear that insurance companies and industries in this country have a legal right to know that information, to screen their employees and to screen their people who apply for benefits. If we take it away, I agree with you. I think we should take it away. But are we likely to do that? In the United States, we've just made it clear that it's constitutional to screen employees for drugs. It's very hard to think you couldn't screen them for public health measures that were at least related to their job.
Robert?
Yeah, I just wanted to give a couple of examples of, in the early 1980s, I remember there were signs up on the Harvard Science Center bulletin board which were saying that Harvard undergraduates for $75 a shot could donate sperm, and this was a way of making money for undergraduates. What was interesting, I had a number of students go to sort of test this out to see what the conditions were, and they would ask you things like, what are your SATs, and things like this. And there was definitely some type of selection going on as to who was a good donor, who was a bad donor. A member of our staff at the New School for Social Research this past spring was artificially inseminated and received was given a brochure of the 3 possible candidates from which to choose. It was like a chemist, a lawyer, and a plumber or something like this. And she chose the chemist, which I thought probably was a bad choice given the exposure to toxic chemicals. But anyway, she probably thought this was the most intelligent one. Interestingly also is that she was given photographs of these people, and it turned out these 3 people all happened to be blondes, which she thought was just a statistical fluke, but one wonders about that. There are other examples one can name. As you may know, India, for example, has attempted recently to ban finding out the sex as a result of amniocentesis. It's maybe extremely hard to enforce that. Another example which is coming up is the availability of growth hormone. Now, I presume that growth hormone is going to be used by people to get taller children and not to get shorter children. There are going to be a whole series, I think, of biases built in because this is 1989 and this is the United States, and these things are going to be fed into a system which is already in place, and those are going to be some of the biases, I think, that get worked out.
Dick, now that we have the capability of determining which people will develop Huntington's chorea early on, what is your practical experience? How many people care to have the test?
I really can't say. The work that's going on here through the Huntington's Clinic is being self-selected, and the bias is great in that the people who want the test right now are coming forward. I think we have, and it's relatively new, I think the number of families are about 5 or so, is that right? Anyway, I think we have other information on other tests, however, such as with Duchenne muscular dystrophy or cystic fibrosis, where we have the capability of doing carrier detection and prenatal diagnosis, and in fact the number of people coming forward requesting that information are much less than we initially thought would be the case. In Huntington disease, we even in the families that we're already dealing with, we have come up with the kind of information that was discussed, and that is that there are people in the families that want to know, and by nature of the way the test is done, we have information that tells us about people in the families who do not want to know. and there is no, at the present time, there is no easy way to deal with that kind of information. How do you deal with, how do you chart, what do you record, what do you do with information on individuals who really do not want to know their status in terms of whether they have the Huntington gene or not, even though they're merrily going along and living their life as if they don't have it, which is what most of them do. They're having their children and raising their family, and you know that they in fact have the gene. There are those situations, a lot of the situations that you could think of that will happen with the human genome are already happening. I think the situations that are going to be different with the sequencing of the human genome are going to be dealing with diseases that are multi-gene in origin, the common diseases, and dealing with diseases that are propensity towards a specific condition rather than specifically cause it. Predisposition or genetic susceptibility to diseases if you live a certain lifestyle, whereas if you lived a different lifestyle you wouldn't have the disease, or if you worked in an environment you were more likely to develop something versus working in a different environment. I think those are going to be the bigger issues. But a lot of the things that with Huntington disease and other diseases that we're dealing with now are already here and present, and we're just starting to learn how to deal with those.
George?
Yeah, generically, this may be the most important problem facing medicine today, which is how do we differentiate, or do we differentiate, between the physician being a physician for a patient, my patient, doctor-patient relationship, and what obligations a physician has to society or to other people who aren't his patient. The family, contacts with AIDS patients, child abuse, gunshot wounds. We have a whole series of things that we expect doctors to report to a public authority or to someone else, and the genome is going to just take that to another order of magnitude, it seems to me. And one thing we have to do is sit back right now and say, well, how much do we want physicians to just be the physician for their patient, and how much do we want them really to serve the public in some way? And we haven't dealt with that really openly in this country. We say we want doctor-patient relationship and it's sacred and confidential and all that, but it's really not. We really want it both ways. We want the doctor to disclose information sometimes and often to authorities.
I know that when I'm in the office with the patient, my primary responsibility is with the patient, and I don't want to be burdened with the other, but I know that the other exists. Dick, is that your feeling as well?
Well, it clearly exists, and it's the issue of knowing information or having information for other people. If you just limit yourself to the family, people that you feel may want to know the information because you think it may benefit them, but I think in the long run, for lots of reasons, they might want to know the information, or you might need to get material or to get information from them to help you deal with the person that you're dealing with, your own patient. And in the process of doing that, you're going to learn about their status too. Although, I mean, the classic situation is that somebody comes in and wants to be evaluated, and they talk their brother or sister into giving a blood sample so that they can be evaluated, and in the process of that, you find out that the brother or the sister happens to be a disease gene carrier problem and has a particular disease gene, and say is an airplane pilot and has Huntington's disease, or is a neurosurgeon and has Huntington. I mean, there's all kinds of scenarios that you could think of, and we don't know how to deal with that. I agree. We just we don't know how to deal with it. We don't know. I mean, it is so basic, our knowledge of not knowing how to deal with it, that we don't even know how to write it in a record, if a record should be kept of it. We don't know where a record should be kept or how to write a record. Simple as actually making a record of something like that is a very difficult situation.
Anybody want to comment further on that?
No, just that shows that the ethical problems have not been dealt with yet.
Well, I agree with you.
Okay.
I agree with you. I'm not saying they haven't been dealt with. I think that we're trying to
working
start.
on them.
We're starting to start.
A little bit.
A little bit, yeah.
Okay. All right.
I knew we could get some controversy here. Benno, what is the ethical calculus you would use to deny the value of cold experiments in improving life-saving techniques today? Do you write off the contemporary victims of exposure, etc.?
Okay, I think this question is two levels. One is a scientific level, and I would like to use first I would like to talk now first on the scientific level, hoping that those who are really interested in this data follow me on the scientific level. And then I go to another level. And on the scientific level, I have to say the following thing. Russia, who did this work, started his career as a stipend, getting a stipend from the Deutsche Forschungsgemeinschaft, which corresponds to NSF. And during his dissertation, he did a dissertation on a particular test to test cancer. Now, after he handed the work in, some of the referees who looked over the work found out and pointed out that the whole thing is irreproducible and a fraud. Point one. Point two. He published a paper on a particular substance, polygal, where he has as senior co-author a man whose name escaped myself, but I can say it later, who has a fantastic record as one of the great frauds in the field. Now, I would say that if somebody published his dissertation, a fraudulent dissertation, and a paper was a faker, I would not touch this data. I would not even look at it. You know, if I hear of somebody, you know, the biochemists here know the famous cases of Spector et al. And these wonderful stories of these fakers here in this country, I think you would never, you know, these guys should never, they do not get their foot on earth, and nobody would ever even be interested what the hell they are doing later, you know. You would not want to know it, yeah. So from this point of view, I would simply say, my God, you know, if I use now these data, and if I really use it, and if I kill somebody because I believe these data are correct, but they aren't correct, what on earth am I doing? So I would not touch them from the scientific point of view. Now there's there's the other level, and I completely agree with the statement that I think that even if they were good, I would not use them. I would not use them because I think we should remember those who died, and we should not try to squeeze and make some profit out of it. I think we should not. We should not. So that should be a taboo. And I agree that this type of taboo is non-scientific. But I think I strongly urge that one should make these type of fences and taboos.
Anyone on the panel want to comment?
Yeah, I just wanted to say one thing briefly, and that I think that the data probably are, from what I've seen, reliable. If you want to know at what temperature the body collapses, you probably would best go to some of the Nazi data. They're quite simple experiments from the narrow technical point of view. I think the question, and in fact, the issue of whether they can be used or not, I think we have to remember they have been used dozens of times. The military has been in possession of that data since they were first discovered. They've been cited literally dozens and dozens of times. I think the important question is not whether, but how. And for example, I cited those data in my book on Nazi medicine, but it was part of an effort to uncover the broader context and to criticize the context in which they were done. So I would say the question, more important question, is probably not whether, but how those things are used and in what context. And I would say that they should be used only if the context in which they were obtained is included as part of their use. In other words, it shouldn't be just the case that one says, you know, for more on this topic, see Mengele 1942, which, as Bill Seidelman pointed out articulately earlier, has been done. The only other thing I would add to that is that there are some, you know, this is not like a cure for cancer or something. This is of relatively limited value, and I think that's part of what has to be considered. And some of the claims that have been made for the value of it, I think, are somewhat exaggerated. I remember reading somewhere in The Scientist that this might help us deal with the homeless, or it might help us deal with the 50,000 elderly who are hospitalized every year for hypothermia. Well, the elderly, it's not like they need more information on what it means to be cold. They need help with their, I would prefer to spend the money on help with the heating bills and oil bills and so forth. And if you want to help the homeless, research on hypothermia is what, going to develop a better blanket for the street or something? I mean, I think there are some sort of false claims being made for the value.
How would you enforce this, the use of that data? How would you enforce the context?
I don't think the context can, she asked, how can you enforce the context? I don't think you can enforce that. I think you have to distinguish the civil libertarian context, namely the context of free speech. I think people have the right to republish all kinds of things. There's the separate moral question, though, in a sense, which is how should it be done, under what context should it be done, and that would be decisions by editors, or we can make those. But I agree, the enforcement problem is probably impossible.
Bob Pozos will cover this later this evening. Dick, someone asked the question of, given that the guidance for ethical and moral issues related to the Genome Project is still in question, should not a portion of the funding for this project then be devoted or delegated to the ethical understanding of what may happen?
That's exactly what's going to happen. It's estimated that the Genome Project will cost approximately $3 billion. There are 3 billion bases in the human genome, and initially it was thought that it would be running at about $1 a base to sequence, and then the Japanese countered with this was about a year and a half ago, that they could do it, they thought, with about 5 years of developmental technology at 17 cents a base. And Lee Hood came back and said with a little more developmental technology, he could do it for 10 cents a base. And now they're dividing it into countries as to the individual chromosomes. I think that's all the hoopla that goes along with it. I think the estimate is about $3 billion, and it's probably going to take a minimum estimate of 20 years to do the project, and I suspect that the complexity of the computerization and the complexity of the biotechnological methods are such that it's actually going to take a lot longer. We're going to learn more about the genome that's going to take us longer to do than a shorter period of time because of its structural complexity. At the same time, they're saying the NIH is suggesting that they will devote 1 to 3% of their budget to ethical issues, and that money has not been earmarked to be spent at any particular time, but it sounds as if the money is available to start being spent now. So I think that there is, in fact, money to fund research in this area at the present time.
Robert, given the requirement in many states that doctors report the results of HIV testing, do you see any parallels between that and what occurred in Nazi Germany?
Well, there are, of course, many things doctors are required to report, as George has pointed out. It's not just venereal disease, but a whole series of other types of things. I think there are important issues of privacy there. I remember one of the most blatant suggestions I remember hearing was from actually the wife of the director of the Hoover Institute at Stanford, actually said that we should consider a kind of, she used this expression, Star of David concept, where people would wear some type of marking. This is Mrs. Campbell of the Hoover Institute about 2 years ago. I think there's some problems with that, but I think that it's also the case that there are a lot of other diseases for which there's already reporting. Probably the best thing to do is hope that Pat Robertson is never elected, because he would probably take more dramatic measures.
George, someone asked, Larry Bird is one of the last great white basketball players. Let's assume you're racist and obtain the ability to clone him. Do you get in on the action? It seems that economics may determine ethics before or after the fact? Please comment.
There's a long history in this country, as you probably know, of racism in sports, and basketball is probably the most important one. After the Berlin Olympics in 1936, when Jesse Owens won many gold medals, the Germans claimed that he won them that he and other black Americans did it because of their bone structure. And our own coach from Southern California wrote in the 1941 book, quote, "The Negro excels in the events he does because he is closer to the primitive man than the white man. It was not that long ago that his ability to spring and jump was a life and death matter to him." And after an article in Sports Illustrated in 1971 that said that blacks have the superior capacity to relax under pressure, and that's why they're good at basketball, another Celtic, Bill Russell, said, "All the racial upheaval of the 1960s has taught Sports Illustrated was that it's okay to be a racist as long as you try to sound like a doctor." I think he said it all there. And there was actually an NBC special 2 weeks ago that made the same claim, where two physicians were on saying that blacks are better than that. That belief has a long history in this country, and even if you watch tonight, I think the Knicks and the Bulls are playing, many times during that game you will see 10 blacks on the floor. And so we have this thing that, well, the reason they do this is not because whites are no good at basketball, because blacks are genetically superior, and we can't do anything about it. As Richard Lapchick pointed out in the New York Times just last week, whites have conceded the physical superiority of blacks because it fits with their image of the world. Whites still have the brains and the control. And I think that's right. As far as cloning Larry Bird, I've suggested that, actually. And the Celtics certainly have used another Larry Bird this year. That will be governed by the market. I mean, that's exactly what we can look at. I'm not sure who you first have to figure out who's going to gestate him, I guess. But you could do that. That would be the issue, is how much is Larry Bird worth, and then the next, who else you're going to clone? Michael Jordan you might want to clone, and see what the market will bear. They're both great players, but my guess would be more teams are looking for more white players than more black players, and that's a sad commentary on the United States.
Question for Dr. Mueller-Hill. Have you any idea of any of the extraordinary medical care that was given to gravely wounded German soldiers by their doctors? Was rank considered when care was given? Was active euthanasia used on those gravely wounded or brain damaged?
That's a question which I can almost not answer, but I can say that there's some kind of very, very vague evidence that in the winter of 41, euthanasia was used on wounded soldiers in the East. But that's vague evidence. It's not good. It's not well substantiated. Otherwise, I cannot answer the question. I would doubt it. I would doubt that officers were treated better, substantially better than soldiers, as far as I can see.
Robert, you say that the Nazi programs did not arise out of science or medicine in general. How do you respond to Dr. Seidelman's charge that they do?
I didn't say they didn't arise out of medicine. What I said was that medicine alone was not responsible for them. And in fact, one of the points I think I made was that Nazi ideology was not in fact imposed upon the medical community. In fact, it sprang from within the medical community, and you can't simply look at it as simply good doctors who were then abused by bad politicians. The science and the politics were woven together, and in fact physicians considered a particularly propitious time when policies of the state and the interests of scientists were conjoined. This was the Verschuer and other people made this claim. So the only statement I made was that it's not a sufficient condition for you to have a racial hygiene movement to end up with genocide. You need to have a powerful state in order to have it affected.
And last question, Bob. Your remarks suggest that eugenics is not the only kind of science that can be misused. Can you give a historical example of another comparably destructive scientific doctrine?
That's probably not. I think that's probably about the worst that I can think of at the moment. But you could probably name other ones that are quite pernicious. You could certainly name other things that are going on in other countries. Efforts at biological warfare, I think, are quite pernicious. Would be an example I would give. One thing that's not widely publicized is that the Americans were quite interested in harvesting or exploiting the biological warfare knowledge gained by the Nazis. And at the Hoover Institution, there's a list of 200 of the top Nazi biological warfare researchers, and the American military was very interested in exploiting that research. And did so, and in fact protected a number of Nazi scientists who'd been involved in that research in order to be able to use their information later. I'm still on this general question. I think the militarization of science. I just want to repeat this again. It's going on now, and there are things we don't know about that are going on in research in areas of recombinant DNA, the effort to make genetic bomb and so forth. There are all kinds of things going on. These things are largely secret, and maybe people will be holding conferences 40 or 50 years from now saying, where were you and what were you doing with the massive secret programs that were going on in 1989.
George?
Briefly, I think that Bob's absolutely right, that military research is probably, we don't know much about it because it's done in secret. A few things we know, though, that during the 60s, a lot of servicemen were given LSD, not told about it, to see what the effects were. One of those servicemen actually brought a lawsuit after he had been discharged from the Army because he's essentially developed a severe neurosis, beat his children, beat his wife, and became divorced and became extraordinarily depressed. He found out he was given LSD because he had a follow-up letter from the Army 8 years later. It said they'd like to see how you're doing now, 8 years after you've gotten LSD. He had volunteered to test new jackets for the Army to see how they were in the cold, and he'd been given LSD in his coffee that morning. He brought a lawsuit, went all the way to the U.S. Supreme Court. By the time it got to the U.S. Supreme Court, there was one fundamental issue. That was whether the Nuremberg Code that was developed at the doctor's trial in Nuremberg, the one that Art Kaplan talked about yesterday in 1947, whether that code, which again was developed by U.S. judges sitting in judgment in Nuremberg under U.S. Army authority, whether that code applied to the U.S. Army. And our Supreme Court, in the case of Stanley versus United States in 1986, by a vote of 5-4, said that it did not. That this serviceman had no recourse, that our military did not have to follow the standards we set forth in Nuremberg in 1947. And that is a disgrace. And the only way you can change that is to have the U.S. Congress pass a statute that adopts the Nuremberg Code for the U.S. Army. And so far the Congress has made no moves to do so.
We're out of time for today. I want to thank Dr. Proctor, Dr. Mueller-Hill, Dr. Annis, and Dr. King for their excellent and thought-provoking discussions. And you for your excellent questions. There will be a reconvening at 5 o'clock here for the service of commemoration and remembrance. And at 7:15, Dr. Robert Pozos will be presenting his paper.
In principle, yes. Yeah. The cost is pretty expensive. The German version is much cheaper. No. No, I have selected the German version in German. That is cheap. No, no, there is there's an English version printed by Oxford University Press and sold here in this country. So you have just, yes, you can get it. Okay.
In the case of Stanley versus United States, Stanley, versus United States, 1986 U.S. Supreme Court case. I'll mail you a copy of it to get in your car. I know that. Definitely do it. Send one to. That's very recently. Yeah, that's very. Oh no, it's an unbelievably horrible case.
It's something which takes my breath. Yeah.
Took mine.
And there's another one.
Make sure you give me your address.
Yes, yes. You must be my
Right there.
This is not a spiritual concept. If I'd known you were going to be down here, I would have planned dinner with you or something. Yeah, but this is because I have to go home. Kira's singing tonight, but I would have gotten out of it or something. Of course. You screwed it up again. I make you feel suitably guilty.
It's actually in the Daedalus issue on human experimentation.
No.
But anyway, I have
No, I'm not. I never have.
You can certainly write that down.
We expected to come down. We weren't kidding.
No, it's
So your daughter way up there walking.
sit down.
That's great. We're going to be away for almost all of the night.
Right.
Taking a group day for us. And then the group's going to be 3 days in London. We're staying 8 days there. And then they stop us. So we're playing, we stay to
close enough. A few minutes. Yeah, why don't I meet you here?
I'll find you a few minutes before
Great. Oh, no, I'd be happy to. Buck versus Bill, Stanley Mike.
You know, when do we start? I mean, how do we start?
No problem.
When they give us these,
I don't really have a card, but I'll write that. Well, I have one card. I can also look at it. Thank you. There you go.
Up here. Yeah. And the music's going to be straight up the front here. You can, yeah, so we have to go up there. And you should,
No, I'm done. That's it. I'm at Boston University Medical School, Boston. It gets to me. Well, I'll send you the invitation airline.
Well, the other thing is, you should be already sure.
I just have to get my flight.
That's okay.
Oh, he's not there yet either. All right, I don't feel bad then. Okay, good.
Barry, don't want to how do you get paid? I know.
Okay, great. Okay. Thank you very much. Your life. No.